All right. Hi, everybody. I hope you're having a good morning. It wouldn't be a talk for our GI group if people didn't have some sort of food in front of them. So that's great. I want to thank the SCN2A Foundation for letting me come talk today, as well as Dr. Olson. We share a lot of patients. So today, what I hope to do is review some of the SCN2A gastrointestinal related symptoms that I found when I was trying to do a literature review and preparing for this talk, and just review with you a little bit an assessment of what we do in clinic, because I am a clinical gastroenterologist, when we're assessing a patient with neurologic disability and how we go through assessing their oral feeding, their nutritional status, review some of the factors that go into enteral tube decision-making, touch upon reflux, of which I'm sure many of you have seen in your children, and of course, constipation, and then hopefully show you the benefit of having a multidisciplinary approach to your children. So you already heard from Dr. Berg and many of her colleagues a little bit about all the various spectrum of SCN2A variants. But as you know, they can vary in severity and the type of symptoms. And again, there can be a subset with a symptom onset in infancy. And when you initially look what's published right now, they just talk a lot about associative gastrointestinal disturbance. But as many of you know, gastrointestinal and nutritional difficulties are frequently reported in patients with neurologic disability. So again, I thought it would be helpful to review our approach that we use in our clinic for patients presenting with neurologic disability. So gastrointestinal functions such as feeding, nutritional status, upper intestinal motility, and lower intestinal motility, or when they go wrong, the dysphagia, the malnutrition, the reflux, and the constipation are all tied into an infant and child's brain and neurologic development, their overall tone, whether they have hypertonia or hypotonia, or a combination of the both, what their posture is like, their ambulatory status, their seizure profile, and what sort of central nervous system medications that they may be on. And it's known that there's a strong bidirectional communication between the central nervous system and the enteric nervous system under what we call the gut-brain axis. That's why many of my colleagues call the GI tract the second brain. And in fact, neural communication has integrative roles in gut function, and this central regulation plays an integral role in the physiology of the GI tract. And to be honest, we're just beginning to understand the various hormonal, immune, and neural pathways that are involved in the GI tract and brain. And many of my colleagues actually are studying the gut microbiome, for example, and how that impacts patients' neurologic disability, autism, and in the adult world, even things like Alzheimer's. But knowing that there's all this communication, let's review some of the considerations. So the first thing is oral feeding milestones, right? Whether it's learning to nipple feed as an infant, take dissolvables, potentially as a 10-month-old, drink from a cup, or your 3-year-old telling you what pizza they want for lunch. There's many different feeding milestones that have to take place in those first 3 years of life. And sometimes when there's neurologic disability, there can be delayed or difficulties in achieving these milestones. And it was interesting to hear what Dr. Berg said today, because there's a very old study actually of parents of 48 preschool children that had cerebral palsy, and almost half of the parents noted that their child's inability to feed was the first indication of a neurologic issue. And in addition, I will say that speech delays also often tie into feeding delays in infants. In addition, the advancement of oral feeding skills are tied closely to a patient's neurologic development and comorbidities. So if a patient was born premature, that's also going to affect the timing of them developing those milestones. If there's presence of any other anatomic abnormalities, you heard about some of that laryngomalacia, or presence of a cleft palate, for example, or a laryngocleft, that also is going to affect their ability to advance on their oral feedings. For patients with autism spectrum disorder, it is very common to have feeding difficulties. It's very heterogeneous in nature. In the literature, they report about 62%, but anywhere from 30 to 84% of children with autism have feeding difficulties. And these can vary from oral motor delays to food selectivity or sensitivities to various textures, tastes, smells. They can also have a diagnosis of restricted eating or avoidant restrictive food intake disorder, or ARFID, mealtime related behavioral difficulties. And of course, this all ties into then caregiver feeding stress. And when we think about the actual swallow function, which is the oral phase, which requires that lip closure, the chewing effectively, that then you have to move the food bolus to the back of the mouth, which is the pharyngeal phase. You have to lower the palate and then get it into the third phase of the swallow, which is the esophageal phase. This is why we really think it's very important for all children with neurologic disability to have a clinical feeding assessment by a trained therapist. In addition, our team encourages to obtain a video fluoroscopic swallow study to understand all of this oropharyngeal coordination and potentially a child's risk of aspiration, because it may change the method of thickening or pacing of how you're going to feed that child. One of my colleagues in my center actually did this pretty cool study from a couple of years ago that looked at almost, I think it was 450 children under the age of 2 that had swallow studies at Boston Children's, of which almost a third had a neurologic comorbidity. And you can see that the varying types of symptoms of whether a child aspirated or didn't aspirate was very variable. So there was the classic, you think about choking, reflux, coughing, noisy breathing. But one of the messages for you is that actually just the symptom of parents saying they had reflux also was there and may mimic symptoms of aspiration, especially in kids under the age of 2. And one other point just to remember is that kids under the age of 1 may actually have no symptoms at all and be found to have aspiration on their modified barium swallow. This was also brought up earlier too in Dr. Berg's talking about the phenotypes was oral secretions. Those are heavily tied into a child's dysphagia because they often can have decreased salivary control. That's due to lower muscle tone or sensation that leads to decreased airway protection. Sometimes they'll actually have decreased swallowing frequency or medications that can affect their having higher amounts of saliva. Drooling, technically in the literature, if you ask your otolaryngology colleagues, are considered abnormal after 4 years of age. So this can be drooling out of the front of the mouth, or it can be sometimes some of that gurgling that you hear in clinic, or at home, which is that pooling around infants' larynx that then can potentially increase their risk of aspiration. Treatments can include a variety of medications, such as anticholinergics, oral sensory motor interventions, potentially surgical interventions. And these all, again, want to do very closely with guidance by your local OTs, SLPs, otolaryngologists, and pulmonologists. So again, oral feeding, you really want regular monitoring of oral function because it's a dynamic process that may change over time. We heard that in Harry's story that, even after having the seizures, he had to kind of learn how to feed again. So again, it could be a moving target that you want to work with your team. Also, of course, if there's ever any severe illness, last year was an awful RSV flu season, that can also really sometimes change the safety of whether a child can feed effectively and safely orally. We always in our clinic try to promote oral feeding if it's nutritionally sufficient, safe, stress feed, and feeding times are not prolonged. But again, you just also have to be mindful of that oral secretion management. So moving on to how we think about infant or child's nutritional status, we do monitor what we call anthropometrics, right? That's the looking at the length, the height, the weight of the infant and child. But of course, this is often sometimes complex in patients with joint contractures, spasticity, scoliosis. So in general, the trends of your infant and children are very useful to us. We always say to consult with a pediatric dietitian because they also can help if they're having trouble getting some of these measurements to use alternative measures for linear height, such as knee height or tibial length, or skin fold thickness can give them an estimate of a child's body fat. We also recommend in all kids with neurologic disability getting a general annual assessment of micronutrients. And whether it's oral feeding or through an enteral feeding tube, enteral nutrition really is critical to an infant and child's cognitive and neurologic development. It also helps in development of intestinal mucosa, the gut immune system, giving them a diverse flora, and overall helping with their gut motility. So one of the questions that often comes up is, well, when do you consider initiation of enteral tube feedings? In general, we say if there is need for assistance with medication administration, because sometimes some patients can be on many anti-epileptics, which just get difficult for them to take by mouth, or if they have an inability to safely eat or meet their calorie or fluid needs by mouth, or inadequate weight gain and growth. And our European Pediatric GI Society also came together a few years ago with some guidelines for the nutritional assessment of patients with neurologic disability, and they came up with these red flags that you want to look at physical signs of undernutrition, such as if there's any presence of any sacral decubitous skin problems, or if there's poor peripheral circulation, if a weight for age Z-score is under the -2 range, a tricep skin fold thickness is less than the 10th percentile, or a mid-upper arm fat or muscle area is less than the 10th percentile, or faltering weight and or decreased weight gain velocity. I will say in clinic, practically, the one that we use the most is probably that last one listed on that page. There are many options for enteral tube feeding. There are nasogastric tubes. There are ones that go through the nose. There are nasojejunostomy tubes. There's gastrostomy tubes. There's gastrojejunostomy tubes. And there's even something called a primary jejunostomy tubes that we do in certain cases, but not that commonly. And when you require enteral feeding, we usually start with nasogastric or nasojejunostomy tubes first, because they help us understand a patient's general feeding tolerance. It helps us optimize nutrition prior to G-tube placement if they are malnourished. And it allows sometimes, if it's been a temporary virus or illness, that you can then transition back actually to full oral feeding. If you need more prolonged enteral feeding assistance, of course, a gastrostomy tube or a gastrojejunostomy tube, if there's gastric feeding intolerance, can be present. And this is just one of my patients over here on the right. He doesn't have SCN2A, but he has another chromosomal abnormality. And it's just a reminder that G-tubes, that like you've heard earlier this morning, it's not all or nothing. We still sometimes have many patients that do a combination of feeding what they can by mouth, but if they get tired, or if it's just not a good feeding day, that they can do the rest through the gastrostomy tube. And I always use this in some of the slides, in some of the talks that I give, because it's actually a really nice summary that actually was a systemic review of 11 qualitative studies assessing parents' decision-making around G-tube in patients with neurologic disability. And they came up in 3 main concept areas that impacted families' decision around the G-tube that I think we as clinicians probably need to consider when having these conversations. Oops. I was thinking there was a pointer, but there's not. The first one on the left is just knowing where your family is coming from with their cultures, their understanding of what their child's prognosis, diagnosis is, and how they feel about potentially, undergoing a G-tube, their values of what they think in enjoyment of feeding, how they feel about if they will have loss of some of that oral feeding skills if you place the G-tube, and then what information practically they're getting about the process of placing the G-tube itself. And I think if we can probably tackle these 3 domains in a more effective manner and actively engage all of you, I think it makes for a better conversation when the time comes about thinking about G-tube placement. And ultimately, it is for sure just a continual balance. We are trying as gastroenterologists to promote adequate weight gain and growth, and also promote safe oromotor feeding skills and general development while minimizing the caregiver stress and all the points that are going on in the family unit. So moving on to gastroesophageal reflux disease, it is also very common in kids with neurologic disability. If you look in the literature, they say that abnormal EEGs in earlier onset of neurologic disability have been associated in patients to have a higher reflux burden. Interestingly, we think of reflux as both acid and non-acid reflux, and higher non-acid reflux burden has also been found in patients with neurologic disability. Interestingly, for us to keep in mind as gastroenterologists is that this is especially sometimes common if their patients are also found to have significantly delayed gastric emptying. I think because then the meals are just sitting in the stomach and they have more likely to have that non-acid reflux after a meal. Other gastroesophageal reflux considerations include impaired esophageal motility, which can happen in patients with neurologic disability. They can have decreased esophageal clearance, which can then also in turn worsen their reflux symptoms. And then there can be a variety of factors that can worsen a child's reflux. If they're in a prolonged supine, that means lying flat state. If they have scoliosis, which we've heard a lot about this morning. If there's any increase in intra-abdominal pressure, which sometimes can happen with seizures, if there's a lot of coughing, if there's symptoms of an upper airway obstruction and various medications, or if there's an anatomic abnormality such as a hiatal hernia, those can also worsen an infant or child's reflux. And then we have to keep in mind what we call GERD masqueraders. Those are things that seem like reflux, but they're actually not. We already talked about one of them, the aspiration, especially in kids under the age of 2. There is also a phenomenon called rumination syndrome, which is repeated regurgitation and rechewing of stomach contents that regurgitate after a meal. And then milk protein allergy also can mimic reflux in infants under the age of a year. Blenderized tube feedings is a common way now that we use in our enterally tube-dependent kids to help with reflux. It allows for commercially available or homemade real tube blends through a G-tube or gastrojejunostomy tube. One of my colleagues published a paper on how it improved gastric symptoms of nausea, vomiting, reflux, and constipation. There's also some data coming out there now about blenderized tube feeds promoting family engagement, improving their quality of life and inclusion in the family. But I will stress and can't stress this enough that it has to be done with close dietitian oversight, because sometimes also patients with neurologic impairment may actually need higher calorie needs on a blenderized tube feed, and we got to make sure that we're getting their macronutrients, their proteins, carbs, and fat, as well as micronutrients. All your B vitamins, zinc, selenium, you name it, are being met by the diet. But I'm a big fan. Fundoplication is you may sometimes hear about. Certain centers may perform a fundoplication at the time of a G-tube. It's where they wrap the lower esophagus, the stomach around the lower esophageal sphincter to prevent any intractable or gastroesophageal reflux. The biggest thing to keep in mind is that there can be a lot of post-procedural complications. If you can think about it, you now have an obstruction in your lower esophagus. So that's sometimes if you do have esophageal dysmotility or you have oropharyngeal dysphagia, that can lead to worsening dysphagia, gagging, retching, gas bloat, aspiration risk if there is esophageal stasis. And then, of course, sometimes the wrap itself can become slipped and unwrapped, and you need a repeat surgical procedure. This should really only be performed after careful gastrointestinal assessment and consultation with a surgeon. For reflux treatments, we often think of thickening of oral or gastric feeds, like we talked about with blend feedings. Antacids, 100%. If there is acid reflux or any signs of esophagitis, if there's been an endoscopy, prokinetic agents can be helpful if there's delayed esophageal or gastric emptying. And you want to just, again, like we talked about, try to limit some of those other controllable reflux triggers, ensuring all your patients have a stable airway clearance regimen, good secretion management. And I also do promote a good feeding and sleep schedule. Your GI tract does like time off feeds. So it's nice to have that time of what we call the fasting state and give it a break. And of course, fundoplication is an option if there's severe reflux and life-threatening illness. Just one quick slide. This could probably be a talk in itself on a ketogenic diet. I don't consider myself an expert, but I see a lot of kids with the neuro team that is on ketogenic diets. This is a strict diet, high in fat and low in carbohydrate. to reduce seizure frequency. It's a spectrum of diets, and I think it depends on your oromotor abilities of what you can do. It can be anywhere from a modified Atkins diet to a low glycemic diet, and varying the classic ones that we think of, the 2-to-1, the 4-to-1 ketogenic diet ratios. One thing that we always keep in mind as gastroenterologists is that 30 to 50% of patients may have side effects from the diet. So this can include vomiting, diarrhea, abdominal pain, constipation, lethargy, and I know they're always tracking the lipid levels to make sure those are staying stable. Hopefully your team can treat this with dietary adjustments, medication, and other interventions, especially if the diet is going well for the seizure control. I only have one slide on constipation, but I'm sure because I am more of an aerodigestive person, but this is often a conversation in my clinics. Constipation is very common in patients with neurologic disability. We diagnose it by stooling history, dietary assessment, abdominal, and of course, we always like to look at the perineal exam just to make sure that there's no spinal abnormalities that you can see around the anus. We assess patients' tone, mobility. That's very helpful to know. Are they getting on the toilet? Are they not? Are they getting in a stander? Are they not? Because all those things can also help with their defecation. Disimpaction is definitely available if there's a concern for rectal fecal impaction. That can be either enema therapy or higher dose osmotic laxative therapy. And then, of course, initially for constipation, we do standard initial treatments with osmotic therapies or stimulant therapy. Some patients that are very hypotonic may need rectal stimulation with suppositories to help them to go. And there is a whole new world of secretagogues out there for some of the older children that have really changed some of our management of constipation as second-line agents. And of course, another reason we love blenderized diets is that they can helpful for boosting fiber intake, especially for patients that may not be getting a lot orally in their diet. This is just a plug again, as I wrap up for a multidisciplinary team approach. You really want to work with your neurology team to understand what they think about their function and the ability and how that's impacting the GI tract. Of course, there's us, the gastroenterology team, the speech language pathology team. I love them so much, along with our dietitians. We sometimes partner with a complex care pediatrician who sees a lot of our patients that have multiple specialists involved, because I do know that can be overwhelming. We also work closely with our ears, nose, throat, and pulmonary colleagues, and of course, your primary pediatricians. And this is just a slide. It's a paper that we actually have in progress that we were looking at care integration of our experience of patients coming to our aerodigestive center. That means families' experience with care integration across the whole care spectrum, from the clinic, hospital, to the community services. And the dark gray is patients who are in our program, and the light gray are those who are just new to our program. And they break care integration to how families felt with access to care, provider communication, care goal creation, family impact, and team functioning. And it was actually because we spend a lot of time working as a team, it was nice to see that people thought their experience with care integration was higher after being seen in our aerodigestive center. I don't have to tell all of you, but connecting with community and hospital services is very important, especially from the early age. I promote it as soon as you can get into EI, please do. And we love to partner with them. And that's it. Thank you.